either inpatient or outpatient. So inpatient weeks, we start on Monday, and I'm on call from Monday through the following Sunday. So 7 full days until Monday morning at 7 a.m. That's when we switch. And I take care of the very sick patients in our neuro ICU. We have a 32-bed neuro ICU at Tampa General Hospital. It's the second biggest in the state of Florida, one of the biggest in the country. Usually neuro ICUs are 12 to 16 beds, but we're double that because we're pretty much the biggest game in town in Tampa. It's a fairly big city. It's become about 2 or 3 million people if you include the St. Petersburg, Florida area too. We have an encatchment of about 13 different counties that feed into Tampa General Hospital. So if someone is pretty sick at another facility, in this region, they will actually call us to transfer the patient for higher level care for their stroke diagnosis and management. And so we'll send a helicopter. Our hospital has 5 helicopters that go anywhere that we get requested to pick up a patient, and we transfer those folks so we can take care of them. And that's my inpatient week. And, we'll get calls from other physicians in the hospital as well about the patient who, let's say, just had a surgery and then can't move half their body or have some slurred speech, other signs of stroke, and they'll call us. Or we'll get a call from our ER colleagues who say, this 65-year-old man just walked in from the street and couldn't move half his body, couldn't see half of his vision, and the passerby found him, and we brought him into the hospital. Here are his vital signs, and looks like he's having an acute stroke right now. Can you send your team down to evaluate? And we find, let's say he has new onset atrial fibrillation, which is a very well-known cause of stroke. If he wasn't on a certain blood thinner, then that would explain what the etiology is, what the cause is of that stroke. So we'd admit that patient to the neuro ICU, but also potentially give these patients life-saving treatment or treatment that is going to help reverse part of the damage that will occur in the brain. So a lot of people don't realize, but if someone has a stroke and the symptoms started within 4.5 hours, they arrive to the hospital during that time period, we can actually give them a clot buster medication called TPA to help reverse the stroke from leaving damage on the brain. So it's part of my job during those weeks that I'm an inpatient to see if a patient is a candidate medically for that very strong blood thinner, the strongest known to humankind. And so we give it IV over the course of 1 hour, and a lot of times people get a lot better and they can start moving their arm and leg again. They can start speaking again. This is a very rewarding part of my job. It's something I really love to see. It's just so amazing and awesome. It's like the Lazarus effect. People just walk out of the hospital after that, but they don't just leave. We have to find out the cause of the stroke. We have to make sure it doesn't happen while they're in the hospital, because that's a high risk period. Then we got to treat them with medications, IV, and then oral when they go home, so that they can prevent the stroke from happening again. Now, if the TPA doesn't work or doesn't do the trick fully, we have another trick up our sleeve, and that is to call our neurosurgeon or neurointerventionalist colleagues to actually take the clot out of the brain that's causing the ischemic stroke. And so what we do is we call them up and say, hey, listen, I have a patient with an occlusion of one of the pipes in the brain, either the middle cerebral artery, or let's say the internal carotid artery or the basilar artery, for example. And here's what the imaging looks like. We have the CTA, which actually proves the clots there in the brain, the exact location of where it's causing this person's symptoms. And so they'll come in with a whole another set of team and anesthesiologists and so forth, and either put the patient under some sedation or maybe some light sedation, or sometimes even nothing, and just quickly whisk the patient upstairs and pull the clot out of the brain with these new toys and tricks they have called stent retrievers, or there's a vacuum suctioning device, improving recanalization rates, in other words, reopening of those clogged pipes. So I'm just a glorified plumber. In other words, that's what I do, is look at vessels and pipes in the brains and the neck, and to try to unclog those either chemically with TPA or call my friends in to physically remove the clots mechanically. So that's the hyperacute setting. Unfortunately, a lot of people like I said, don't know that time is brain. That's our mantra, time is brain. And so they come in too late to receive either one of these therapies. And so, the best we can do at this point is send them over to a rehab facility and give them medications to help the brain rewire over time, which it does. But, it's a lot less easy to rewire somebody's brain when they're younger. So younger people with strokes have a better go usually than the older elderly patients with strokes who have a difficult time rewiring over time. And I think it's because the brain is more plastic. But that's basically my week in a nutshell when I'm inpatient. The other week, I'm outpatient. And so I see stroke patients in the clinic, again, referred from other neurologists or internists, cardiologists, and so forth, who maybe when they were seeing the patient had complained of some slurred speech at some point or some hemi-body weakness, something like that. And they said, you know what, you should go see a stroke specialist. Or maybe they got an MRI for headaches or for something else, and then they'd have found incidentally a silent stroke, which maybe not, what wasn't so silent on their brain MRI, and so they want us to comment on that and find out what the cause of that was to prevent the next one.